Really excited. Wonderful talk, Brian, especially in commemoration of Brian. He was true a mentor to most of us and to all of us. He really set the standard in terms of his enthusiasm for his prostate cancer patients. Um, I have an opportunity now to also talk a little bit about focal therapy, and some of the clinical trials, concepts, and challenges. Can you see my screen?
I'll use the other one.
Yeah, yeah, your screen's
Chase.
up, Steve. You're good.
Okay, great. Ac- yeah. Chase, I'm using my screen to go through the slides. Are you showing a different slides up there?
Well, that one has a ski family.
Okay, perfect. Then you're seeing the right ones. All right. So, yeah, just wanted to say I wish we were up there with you and doing some skiing. Here's my family. I've got my four girls, Haley, Jane, Maddie, Lila, and Charlie, and my wife Ivy, the veterinarian. And look forward to the opportunity to return next year and perhaps enjoy the slopes together. Today we'll talk about a little bit about focal therapies, and I think when we talk about focal therapies, I think the stage was set nicely by Dr. Davis. When you think about, there's a couple of different approaches that we're seeing, and it's really exploded in terms of technologies. You have thermal ablative technologies and what I would call non-thermal ablative technologies. Those that are thermally ablative are those that are HIFU, cryoablation, and focal laser ablation. And then the non-thermal are irreversible electroporation, water vapor, vascular targeted photodynamic therapy, and then we have radiation therapy. I'll be focusing my talk on radiation therapy as an oncologic approach during the course of this talk, with the goal, of course, with focal therapy being cure and quality of life. Optimally, patients want to eliminate that disease, and then they want to make sure that they don't have any bowel complications, they're not incontinent, and that they're able to maintain their sexual function. And so it sounds fantastic in theory. But from an anecdotal experience at our institution, we ran a protocol with Michael Zalewski, Memorial Sloan Kettering, MD Anderson, and we did a focal therapy protocol on very low risk patients. But the trial was not successful. And in fact, we had to shut the trial down because, as a prerequisite for patient enrollment, they had to have another biopsy, and that biopsy had to be demonstrated that was no additional disease. And virtually every patient through another biopsy had multifocal disease, and we could not accrue that trial and had to shut that trial down. And that was in very low risk patients. So I say focal therapy goals are great, but multifocal disease, it initiates more procedures on patients. Less is not it's not necessarily less can be more, and you got to show us the data. I mean, I think the data, is the critical piece. We now are living in a PSMA world, MRI world, and all of this makes the definitive management of prostate cancer with focal therapy a non-standard approach, as evidenced by other experts around the community with NCCN guidelines. Here's an example of a dominant lesion that's identified on not only PET, but also with MRI. And it shows it classically, well, this is a great way to facilitate that treatment. And in a lot of the urologic literature, we see multiple different communication approaches, whether it's focal, a quadrant ablation, hemiablation, hemiablation anteriorly. You might hear about this hockey stick ablation or subtotal ablation. So all these different type of quote approaches are trying to tackle and prevent the whole gland approach. I will talk about a little bit, as you look, there's a nice systematic review of oncologic results and cancer control definition and focal therapy. I'm going to stay focused on those that are specific to the radiation for this particular talk. Here are all the different modalities that have looked at focal therapy in terms of HIFU, cryo. You can see in the focal brachytherapy, you've got biochemical range. I mean, it's really all over the maps. The studies reporting salvage treatment are also noted. And I do think that focal therapy has a place, and I think salvage is going to be the place for focal therapy. If we look at what are we going to define as cure in the focal world, it's very difficult. This is an example of 15,000 patients that we looked at to come up with a surgical definition of cure with 0.2 at 4 years. And this is a nice this is a great way to articulate and help the patients know what their expectations. In a focal therapy world where you're not treating the gland, we don't have a definition of what is considered success. Cancer control definitions in focal therapy have varied. I mean, here are all the definitions. You got the ASTRO definition, you got the Phoenix definition, you got modified, the Stuttgart definition, you've got another Huber definition, you got a Nader plus 0.5, you've got an AUA definition, a salvage focal retreatment definition, and then a radical treatment. So you've got all these different definitions of focal therapy, which makes the data difficult to truly assess what is appropriate. Here's some studies that have been done on focal therapy in the published literature for brachytherapy. Here are some midterm outcomes of iodine 125. You can see here, this is a focal therapy done with patients with Gleason score of 6 and 7 disease. These are low in 82% of the patients, about 18% of patients intermediate risk disease. And you can see survival is going to be excellent in these groups of patients long term. Here's an example of some data that was done within the Mass General group. They use 125, iodine 125 at 145 gray. And you can see that this was all done with MRI guidance and very focal, treating the peripheral zone. And you can start seeing that for the intermediate risk patients, this focal treatment was not successful. You can start seeing the biochemical PSA failure rates dropping off very quickly after treatment. And so this is an example of utilizing optimal imaging in a definitive setting, but not achieving appropriate cure. Here's another paper with a selected low-risk prostate cancer patients looking at quality of life, IPSS and IIEF at 2, 6, and 12 months. And I think when you look at that data, it's very compelling, right? The urinary symptoms and the erectile function are going to be good. And that is the goal for patients who decide not to have active surveillance, but want to have something done. And so through that, they get something done and they have good urinary and erectile function scores. Here's an example from a study done with an Australian institution with iodine 125. And I think the PSA here sort of speaks volumes. You can sort of see it drops, it bounces, and it moves in multiple different directions that are going to warrant additional biopsies to confirm whether there is residual disease or not. So when you move into a focal for definitive treatment, you are going to subject the patient to more biopsies and more procedures down the road. Here's an example of iodine 125 to 160 gray. This is a medium-term oncologic and functional assessment. You can see here on the PSA, years after treatment, the PSA is between 1.5 and 2 and a little bit higher than 2. Here, these are the years after treatment. You can see the IPSS score actually has a little bit of a bump at 4 months, even with focal therapy. And the IIEF has a little bit of a drop, but pretty much is consistent. Again, what do you do with that PSA? Here is the ideal 2A phase 2 study of ultrafocal brachytherapy for low and intermediate risk prostate cancer. And so what you see here is sort of an identified lesion on the left. This went to 160 gray to the MRI defined lesion. And you can start seeing that, again, the PSA is very difficult to evaluate with the IPSS and IIEF scores being consistent. So while patients' quality of life is great, you're going to generate anxiety potentially in these patients with PSA management. Here is MRI. When we start thinking about HDR, HDR now is being looked at in many different ways for focal therapy, and here are a few different studies that have assessed it. This is 19 gray times 1 fraction, and we have to remember there's now been a randomized trial demonstrating that 1 fraction is simply not enough, even in the whole gland setting, that you need at least 2 fractions, and data is emerging that maybe 2 fractions is not good as 4, but that's coming out of the group in Michigan. And so when we look at here, the NCCN intermediate risk at 26 patients, you can start seeing the biochemical disease-free survival starts to drop off. And these are intermediate risk patients who with whole gland disease will have very high curative intent. Then I think what was interesting about this paper is they talk about biochemical disease-free survival with salvage. And what that tells me is these patients are going to get double dipped. You're going to treat them once, and you're going to come back and end up treating them again. And yes, you can extend patients' biochemical survival through multiple treatments, but is that what we are aiming to, and is that our primary goal in the definitive setting? Here's another paper, 20 gray, 1 fraction, in-field control rate drops to about 80%. And you can see this is Gleason score of 6 and Gleason score of 7 patients. So the probability of survival function in in-field control is dropping off in these patients with 1 fraction. Probably not enough dose within the concept of focal therapy. Here's another 20 gray and 1 fraction study looking at, this is a pilot study. You can see on the left, this is the focal LDR. You can see what the PSAs do. They're sort of bouncing up and down. The numbers themselves reflect the number of patients within that subcategory. And here you can start seeing that, you know, the PSAs, you're just going to have multiple conversations with these patients about what am I doing with my PSA? How am I going to manage this? And what is the next steps? Requiring additional, not just biopsies, but probably saturation biopsies. And then we look at the middle, which is, you know, the SHIM score and then the IPSS score. And you can see across those that what you're trying to do is minimize severe erectile dysfunction, but still in some of these patients you have it. So I think when you look at what is the goals, we should not be seeing any severe erectile dysfunction in these patients if the aim is to preserve erectile function and also prevent incontinence. Here's another study. This is just the feasibility of an MRI guided for localized disease and focal radiation. It's called the ProFocal trial. And this again was 20 gray in 1 fraction. This was more feasibility of doing it under MRI guidance. Here's a higher dose study looking at 24 gray in 1 fraction. And you can see here, these are Gleason score of 6 and 7 patients, 62% were Gleason score of 6. And then you can see that biochemical control is just falling off. I think we would all consider that to be somewhat unacceptable for a biochemical control approach. Again, you'll be managing PSA on these patients and doing multiple procedures. Here's some of our early outcomes for local salvage treatment. I do think this is the area that I think brachytherapy is going to thrive because you can give extremely high doses with high heterogeneity in the dominant lesion without concern of toxicity in that particular field. Here's an example of a recurrence for salvage, and you can do it focally. You can also place in some hydrogel spacer. So in conclusion, if therapy can cure whole gland, it should be able to cure focal disease. And so in the context of radiation, brachytherapy is an excellent tool for managing individual disease in a salvage setting. However, in a definitive setting, there's tremendous heterogeneity in treatment approaches. There's only been 1 randomized trial. The biochemical definitions of disease control are very heterogeneous. And really, I stress that it's an option really probably best suited for recurrent disease that's focal in nature. Mars clinical trials are needed, especially comparing against other methods, and template guided saturation biopsies should be required prior to initiating any type of focal therapy. So thank you for your attention.